And it's my pleasure to introduce Josh first, who will then be followed by Rob, and then we'll have discussion, including Q&A. Josh Tepper.
Thank you very much to Anton, and thank you for the opportunity to present what is probably one of, personally, the most important policies that I've had a chance to be involved with at the Ministry of Health. It was only about a month and a half ago, maybe 2 months now, that in the clinic I work at around the corner, one of the nurses I work with was held at knife point. And was fairly certain that she was going to be seriously hurt or worse. I've worked in a number of emergency rooms where I've been hit or subjected to anti-Semitic comments. I have friends and nurses and physicians and physiotherapists who I've worked with, who I went to school with, who are working part-time now or not working at all due to physical or emotional challenges. And I'm fairly new to my career, all things considered. And so the privilege of speaking today, and I thank you for this privilege, is incredibly personal to me, and the chance to work in the Ministry of Health on an initiative of this type is incredibly important. I think it's hard this is sort of in some ways the untold story. I think if not this is really the thing that doesn't grab the front lines of the media. It isn't the types of things that ministers or others tend to spend a lot of time talking about. And yet, as I'll talk about and in a few minutes, has a tremendous impact on our healthcare system, and the potential to begin to affect change in this area, I think can be as dramatic and as important as any other healthcare initiative that we're undertaking today. So HealthForceOntario, and I suspect there isn't an organization in the room that hasn't been a beneficiary in some ways of the HealthForceOntario strategy, is quite broad, and it's the government's multi-year health human resource strategy. We're currently in our 5th year. And our 3rd minister, who's been a champion for our strategy. And I usually get a little farther in before they mute me, but I seem to be on a roll today. All right, there you go. Then they remembered that I had funding power, and they turned me back on. There are very few privileges in the ministry, very, very few. But I mentioned the minister, and suddenly they're like, oh, wait. So this has been very broad, and there are hospitals here that I've seen that have participated in our HealthForceOntario locum programs and emergency room coverage. There are individuals here who participated in our PA program. There are those who have benefited from our large increase in nurse practitioner programs. It is an incredibly broad strategy. We've done huge increases in the supply and the distribution of healthcare providers right across the regulated and the unregulated professions. But like I said, one of the really untold stories of our strategy is the healthy work environment. So one of the first things we needed to do was get a definition. And so I had been participating from really in the first few months of my time as the first sort of ADM of HHR in Canada in this national organization, a great organization, the Quality Work Life Quality Healthcare Collaborative. And so we decided that this was a very thoughtful definition and the one we've chosen to use. It's a work setting that takes a strategic and comprehensive approach to providing the physical, cultural, social, and job design conditions that maximize the health and well-being of healthcare providers. And I think there are probably a couple dozen, if not more, definitions in the literature. I think this is as good as any, and it's one that we've used to great effect. there are two important things about this slide. First of all is the content, and the second is that I probably could have given an hour presentation just on data. I probably could have stood up here with slide after slide after slide, and mic after mic after mic. Great. And for those of you on the phone, that concludes my talk. Thank you very much. So I'm not going to read all of these, but just a few key stats. The average number of days of work of lost is 1.5 times greater for healthcare workers than for all other workers. And for certain professions, we are much, much higher than that. This is an aggregate average across all healthcare providers. Nurses, paramedics, others, much, much higher. Stress-related absences cost more than $10 billion a year with a $14 billion impact on the healthcare system. 28% of Ontario nurses assaulted just in the last 12 months. 75% of Canadian family doctors reported abused by their patients. Medical students, 40% more likely to experience moderate to severe depression than the general population. These are well-educated, generally well-off, well-supported individuals, in a fairly highly structured social environment, and still having, a 40% more likely odds of experiencing moderate to severe, not even mild depression. 1 out of 6 employees report being bullied at work, and 15% of those, fewer than 15%, seeking help from the manager. And this is a room of managers and leaders in this room, and that's such an important thing to keep in mind. And reducing the absenteeism rate for healthcare workers to the Canadian average could mean the equivalent of, imagine this, 13,700 additional, basically, hours of full-time employees, including 5,500 RNs. We talk so much about the shortages of healthcare providers on the front line of our systems, and think about just bringing us down, not eliminating it. This isn't a zero policy. This isn't, below. This is just to hit average. Imagine the impact that this would have. And, it was interesting, just fewer than 15% go to the manager for help. So I shared this very difficult story of the nurse I work with having been threatened, and ultimately the patient in question grabbed a chair and threw it through the wall, and then banged his own head through the wall. And then not less than 5 weeks later, we had one of our managers come in to do their annual sort of check-in for us, and what do you need, how are your supplies, et cetera, et cetera. And they said, well, talk to me about safety. And I couldn't believe it. The nurse sitting there said, well, it's pretty good. I just sort of said, wait, let's go back to the wall that hasn't been repaired outside in the hallway and talk about safety for just a minute. And, and to be fair, my clientele, I work in a very inner city, poly-addicted, poly-substance abuse, strong mental health. It's not a typical population. But nonetheless, I was staggered that at the same time I was sort of referring her to the Mount Sinai PTSD trauma clinic to try to get her some support to deal with this, when given the opportunity to seek additional resources, was ready to minimize it. And I said, no, actually, that's not right. And so now we're looking at bringing in some panic buttons and some other types of opportunities. But again, we just have to keep in mind how hard it is for our frontline team to be able to articulate the challenges they face in this area. And it may not be as dramatic as knife point or being threatened with that type of violence. It could be as simple as having to lift really heavy patients each and every day, or having sharps that aren't safety prepared, although as we'll talk about, that's less often. So why are they so important? Recruitment and retention, I think, is obvious. Patient safety and quality of care. And this is one of the most important points I want to make in this slide deck, which is there's such an important and wonderful focus on patient safety and quality of care, the Excellent Care for All Act, the patient safety agenda, the champions we have there. I would argue that the healthy work environments and the care and well-being of our frontline care providers is the flip side of the same coin. It's the flip side of the same coin. You cannot truly have a patient safety quality agenda for patient-centered care without having a healthy work environment strategy. They are simply the flip sides of the same coin. And in fact, there is a 2008 study that sort of showed this correlation, that in sectors which had a good healthy work environment and a strategy for it, that they actually had better outcomes on their patient safety. And so we have to keep that in mind. And then the sustainability of healthcare costs. We all live and we all read the Bending the Healthcare Cost Curve, the TD reports, et cetera, et cetera. this is such, I gave you just some of the basic stats, and I could give you more and more and more of the economic model that supports a really strong, healthy work environment strategy. And then the final thing that isn't on this slide, it's just one of those things that's the right thing to do. And I couldn't have these 3 bullets, and this would still be the right thing to do. And I think it's so important that there's sometimes just things in our day-to-day that are in our responsibilities that are just the morally conscionable act to undertake, and I think this is one of them. We have a model which guides us, which was adopted from the RNAO and from the nursing leadership, and I won't spend time on it, but we did work very hard to make sure that we weren't just sort of randomly taking ideas and throwing them out, but we actually try to map all of our initiatives against a strategic model to make sure that we're building piece by piece a comprehensive strategy. And it's also important to recognize that there's great literature out here. And there is very thoughtful academic work, and there's thoughtful practical work out there that we can benefit from. And this is just a small example of the breadth of types of initiatives that the team has been involved with. And I'll take a second here just to say that John Amadeo, who I saw walk in, and Adam Nagler are the point people. I have the privilege of standing up here and speaking, but these are the point people on the ground. Many of the people in this audience, I know Rob and others, have worked with them hours and hours and hours, bringing our strategy to life. And what you can also see is multiple ministries, basically all parts of the Ministry of Health, and then multiple ministries that are involved with this. Ministry of Labor, all sorts of ministries, education, et cetera, TCU, advanced education. And I'm not going to spend a lot of time. I want to turn this over to some remarkable stories of accomplishments that Rob has to share with his institution. But just to say that one of the important things we've done is that we've appointed 2 champions, and Rob Devittt is one of our champions who's here to speak about his personal initiatives today. We recently co-sponsored the inaugural awards at the Health Achieves just about 10 days ago or so, with our platinum, our gold, and our silver recipients of this award. And then we've been able to fund a large number of initiatives. And again, I just want to take a pause, and this is maybe the second most important thing today. This is small money. Healthcare system has probably spent this since I began talking. This is not the ERALC $100 billion sort of strategy. Poor Ken, that's not actually what he gets. And we're like, really, I have $100 billion? But this isn't the $100 million strategy. These aren't the tens and tens and tens of millions of dollars. This is small money, and yet the types of results and return on investment that we've been able to realize through really quite modest investment is remarkable, and all done through really strategic partnerships. And so again, I think people will often say, well, Josh, that's a great strategy, but in a time of constraint and economic cutback, this is not the time to be advancing this type of agenda. I would argue more than ever this is the type of time to advance this agenda, more than ever, and that we're not talking about 20% of your organization's budget, far, far less. And all of our tools, and dissemination is so key here, are on our website. We've recently been the first ministry initiative to launch on a Twitter feed, and Rob and others are tweeting. He's not quite up with Justin Bieber yet, but we have high hopes. He's cuter. It's there. And again, I'm not going to take the time to go through this, but basically the breadth and depth of these these are national partnerships, system-level partnerships, small CCAC-type home care organizations or hospitals to large urban-based organizations. So our strategy has basically funded initiatives right across the board. And this is an area that we will continue to work with health system leaders and frontline managers and frontline care providers going forward. Thank you so much for the opportunity to speak today.
Great. So what I'm going to do is take a few minutes to tell some real stories, and using East General as an example, try to bring to life the policy directions that Josh has spoken to. And I want to say it's been a real pleasure to have in government Josh and his team. I think it's one of the most under-recognized initiatives of the government, and yet, building on what Josh said, I think it's absolutely crucial at this point in time. So I'm going to talk a bit about the East General story. If there's 2 takeaway messages after all my slides, the 2 things to remember, we're only just beginning at East General. We're not done yet. And the second one is you can do this on a shoestring budget. It doesn't take buckets and buckets of money. So to talk a bit about our experience, we really started in 2005. We did a staff satisfaction survey. The number one thing the staff told us they wanted was a gym. So we creatively went about securing donations to buy equipment and found a little room down in the basement, and we outfitted a gym. It's open 24 hours a day, 7 days a week, 365 days a year. It's got security cameras in it, so it's safe. Card access, anyone can join. I think it's $3 a pay, and that gives them full access to the gym. The staff then said, we want more, because wellness is more than just a place to run on a treadmill. We do enough of that at work. And so we then in 2007 opened a wellness center. We took an old operating suite that was out of commission, full of like inappropriate space to do anything clinical in. It was space that ultimately is going to be torn down. We threw a coat of paint on it, went to the dollar store and decorated it, went out again and got some creative donations. And in that area, we have a spinning studio, we have a yoga room, and we bring therapists in, massage therapists, acupuncturists, who provide service to our staff. You phone and book an appointment. Because they don't have overheads to pay, the cost per treatment's very low. The staff love it because it's on site. We love it because they take advantage of our benefit program for the full-time staff and get more mileage out of the annual quantums that we have in that program. We also have a running club. When we went through a recent assessment by the National Quality Institute, when the surveyors came to be welcomed at the hospital, we had the hospital's hula dancing club recognize them. That's how broad a wellness program can be. We also then went on last year and developed our first mental health wellness strategic plan. You know, we don't talk a lot in healthcare about the mental health wellness of our workforce. These are grueling jobs. We see people at their absolute worst and in some of the worst times in their life. And I'm amazed how every day healthcare workers come in, suck it up, and deliver great care. But it's important that we as employers have plans in place to deal with the emotional drain that puts on our workers. So we developed a plan with actions, targets, metrics to continue to improve the mental health wellness of our workforce. All of this, the wellness program, the choir that we have, the hula dancing club, the running club, all of it supported by 0.6 of an FTE, and that's it. All the rest of it is staff-led, staff-driven, programs by staff, for staff. The other track that we've been focusing on is workplace safety. East General had a terrible workplace safety record. We had a very high lost time rate. We were paying surcharges on our WSIB assessment. We really saw a need to reduce workplace injury. And so we started with many of the same initiatives that other hospitals did, lift training, that sort of thing. We were the first hospital to go needleless. We looked at the economics of needleless systems and at first blush said, we can't afford this. Then we stepped back and took a second look and said, you know, we need to think of this over the life cycle of an employment relationship and in terms of risk, and risk of someone having a needle stick injury and ultimately getting some sort of blood-borne illness as a result. And we need to factor in all those costs to see if that justifies needleless. And we went fully needleless. And then we worked very closely with the ministry as they developed their needleless regs to prove the business case on a provincial basis. And that has been huge for us in terms of not only reducing one type of injury, but in terms of sending a message not only to our workforce, but our management team, how seriously we take workplace safety. We've improved our return to work programs, and we have a much more robust and aggressive accident investigation process. And we take the same principles here that we do with the culture of safety for patient care. It's blame-free. It's not about you were bad, you didn't follow the rules. It's about how did our systems fail you so that you weren't able to follow the rules. And that leads to a much better environment for improving safety. Our lost time rate has dropped, so we're now below the peer group average. Yesterday I got our near numbers. We are going to get about $170,000 near rebate for last year. We've really dropped our numbers, which is showing me this is all working. Violence has been another big aspect of our wellness initiative. And I've worked in healthcare all my life. I've been working in healthcare, and this is why I'm not Justin Bieber, since 1976. Was my first job in an Ontario hospital, washing pots of all things. I had no appreciation for the impact of violence until one day, a few years ago, I talked to our security manager, who was just walking by my office with reams of paper, and he said, I just finished the annual statistics. And I naively said, what statistics? And they were statistics on the number of calls that our security people had gotten on different things, thefts, complaints, and violence. And I was floored when I saw how many incidents of violence or the potential for violence were happening at East General, leading to a call to security. And here I'd been at the hospital, I don't know, 5 years. I knew there was the odd incident that you'd hear. Never really stopped to think about how severe the problem was. And that really motivated me and the leadership team to do something. And the other thing we quickly realized is we never talk about it. It's sort of our dirty little secret. And when I went and talked to staff in, let's say, the ER, the initial response was, yeah, we've been hit for years. It comes with the job. And I thought, what a sad comment on how accepting we've become of something that's absolutely wrong. If you work at Sears, you don't go to work expecting the customers to lash out at you every shift. And yet in healthcare, we've kind of grown to tolerate it. It almost felt like the old-fashioned attitudes we had about sexual assault, where for some reason people used to think it was the victim's fault. And it's not. We have to put systems in place. So we really became motivated to do something. And the risks in our hospitals are real. This is just one example of something that a patient left us last year at East General. Here's a few more examples. 1 year, and there's even more. And we just pulled some of that we actually keep a drawer of these things. What also struck me as we stopped and thought about it, the things you see on the right-hand side, you obviously think of as weapons. The things on the left-hand side are everywhere in our hospitals. In many cases, right beside the bed or the stretcher, and yet they're weapon risks. And so we really stopped and said, we need to rethink our whole approach on how we deal with violence. So that was December 2006. I had that conversation with Rocky Prosser, our manager of protection services, and we did everything wrong in terms of the next step. I said, this is wrong, we've got to fix it, and I formed a committee. And that was good and it was bad. The good news is, this working team we formed together had on its staff and management organized labor. We reached out to the Ontario Nurses Association and said, notwithstanding the usual approach, let's get just the president, I know that ONA has special expertise in these areas. So we reached out to them and they sent us someone very willingly. OSACH, which now is a new name, which I can't remember, on this group. And we got this group together and immediately started, we said, we have a problem, let's start working on it. And I say I did things wrong. One of the good things that the group pointed out to me was that this has to be done within the context of our Joint Workplace Safety Committee. Great idea, and so we did that. But what we also did was very quickly developed a policy. I think, if I'm not mistaken, within 2 meetings we had a policy out on workplace violence. And how often can you turn around a policy in a bureaucratic organization like a hospital in 2 meetings? Out and posted. Signage. We had signage posted all across the building about our zero tolerance for violence within only a few meetings. And I'll talk a bit about the signage in a minute. Threat assessments. We started a process where we go into departments, a team comprised of people from that workplace, people from the hospital but outside that workplace, and an external consultant to go in and look at violence risks. Because what is normal to the worker is a threat to a fresh set of eyes. And to find new and sort of creative ways to try and reduce risk. We've done training, we've brought in communication systems, tracking systems. The manager's stats weren't even the full numbers. Because if you didn't report an incident to security, but went right to occupational health, security didn't know about it, and vice versa. What are some of the results of this? Well, we've done regular surveying of our staff, and you'll see that the way they perceive personal security and safety in the workplace has absolutely improved from about 72.9% now up to around 80%. So we've seen the staff themselves feeling a difference. In the early days, the feedback was, this is great that management's doing this, but nothing will change. So I expect that attitude would be in every hospital. You have to make change and be visible about it. One of the other things we're doing in training and development, because this is more than just a program, creating a healthy, well workplace is all about changing a culture. So one of the things we've done is tried to create a model of distributed leadership. Shrinking, we have a very flat organization at East General, but one of the things we do is try and bring leadership skills and leadership permission to frontline staff. And we have a program called 1001 Leaders, which is open to any employee and any physician. And it teaches basic management skills, problem-solving skills, and the senior team goes to every cohort going through this program to say, we're not only giving you tools, you have the permission to use them. Like, don't just take the tools and feel you can't do anything with them. And that's been crucial to helping us find lots of micro-innovation to improve the workplace. I think measurement has also been a key part of how we've changed our culture and changed the health of our workplace. We've used standardized survey instruments for years, and in fact, in the first 4 years of our journey, we did staff satisfaction surveys every quarter. Now, most hospitals have historically done these every 2 years, sometimes it's every 3. By the time you resurvey, you forgot what the first results said, and that sort of sporadic, once-in-a-while process does not facilitate quality improvement. So in the first 4 years, we set up a mechanism where over the fullness of the year, every employee would get one survey. But we did it in quarter-by-quarter tranches to give us as close to real-time feedback as we could. Results publicly posted with action plans. So it's not just, geez, the results are bad, it must have been because of whatever. It's, here are the results, here's what we've heard, here's what we're going to do about it, here's when we're going to do it. I think with all that, I think you've seen we've done well, but I think we have challenges ahead, and I'd say this for the whole industry. And I think these are things as leaders we all need to think about. With the recession, with economic pressures, all of our workplaces are feeling pressure, and all of our staff are facing fear. We have to resist every temptation we have to cut these sorts of programs. You know, when times are tough and it's a question of, do we maintain a service on the clinical side or do we invest in our workplace? I say invest in the workplace. It'll actually give us productivity. It will give us reduced sick time. It'll give us reduced absenteeism, lost time injury, and that'll allow us to actually maintain volumes. So I know in decades past, when times were tough, these sorts of programs were often the first to go. And at East General, we've put a great big wall around them and said, we're not cutting there. I think we're also finding in these challenging times a lot of uncertainty, a lot of rumors. I continue to be floored as a leader how, despite lots of good work, a rumor will run through the organization. And I'll talk to you in a minute about some of the things we've tried to do to fight rumors and get the facts out. I also think in tough times, there's a natural tendency to focus on the negative, and there's lots of rhetoric. And I think particularly in an environment that, and I can maybe say this more than Josh, given the political cycle leading up to an election, we've just had all sorts of conversations provincially about wage freezes. Like, there's a lot of noise in the labor space. And I think we have to be mindful that it's there, but stay the course. I think a couple of other things we need to realize as leaders, and all of us as healthcare workers, not only leaders, but all our frontline staff, is our work is more than a job. And yes, it is a job and it's employment, but as leaders, we absolutely have a key place to, as people who are agents of change. We're also in a position of privilege with the people we serve, the patients that, whether it's our nurses or our physicians or our physios serve. And we really, the expectations of our clients are so much higher than our expectations when we go and get service in the retail sector or in the service sector. And we need to make sure our people are as up to the pressures of the day as we can make them. We also, I think, in these times have to recognize the concern that staff have about their family and their friends in the workplace. As we move through new staffing models and change in our organizations, we often fall into a labor relations mindset. And I don't mean that in a pejorative way, where the collective agreement says this is how you bump and this is the process and everyone knows that, so we'll just go through it and everyone should be happy at the end. Well, the fact of the matter is, teams in healthcare that work together become almost like family. And as we make these changes, we're ripping apart clusters of people who have worked together for decades and repopulated them. And yes, they still have jobs and they still have benefits, but it's a huge impact. And we need to talk about it. We still may be required to make those changes, but change made with an understanding of those impacts will, I think, go a lot more smoothly than change made under the mindset of, well, I followed the collective agreement, what's the problem? And I think it's something we often forget about. I also think the reality is we may well see a bit of a dip and then a rise over the next year or two as we go through some of the transitions that are happening in our system. I think some of the strategies to deal with those pressures are things like the following. We need to provide avenues for staff to deal with uncertainty. As leaders, we need to be out and about, and that gets to the second bullet, communicating directly. My senior team do walkabouts all the time, and it's not scripted walkabouts, it's just walking around. You need, as leaders, we need to be out there providing information and in a visible way, not by memo or by email or even by blog. Personal interaction is still important, very important, and should be the primary form of communication in a human service organization. We need to communicate in multiple forms, and I've listed some of the ones here. One of the things we've started at East General is a rumor buster program. If people have a rumor, there is a SurveyMonkey thing they can send the rumor to completely anonymously. The rumors get sent to every member of senior management, and we post a response for rumors within 2 or 3 business days. And that's as a way, I mean, it's amazing how I can go out and do a town hall and say, we're not anticipating any layoffs in the next quarter. And by lunchtime, the chatter in the cafeteria is they're going to lay people off in this department. So that's been an interesting program. One of the things we've learned on it, though, is we've gotten a lot of stuff that isn't rumor, a lot of stuff that's sort of editorializing, and we're trying to figure out a way to respond to that. Because what it's telling me, it's not so much the editorial comment, it's telling me we're still not getting our message out if people are feeling this way. And I think the other thing that's so important is as employers and as leaders, deliver on our promises. I think the Excellent Care for All Act is a great piece of policy. I'm really happy to see us moving in that direction. My worry is a lot of hospitals, as a result of that, will re-engage staff satisfaction surveying, and they'll do it once every 2 years because I think that's a minimum requirement, and we'll get into that cycle of, well, we did the survey, and now we don't have to worry about it for 2 years, and 2 years from now they'll do it again. The results won't be any better, and people will say, oh, well, that's because of the circumstance we're in the moment, as opposed to making it a real tool. So you've got to use those things, identify issues, and deliver on promises. Some of the results that I think show that what we're doing at East General works. We were the first hospital to be listed in the 2010 Great Places to Work. We decided it was really important. We were surveying ourselves against healthcare, and generally speaking, I would argue our staff satisfaction in our sector is bad. But when you're comparing against bad, it's easy to look good. And you kind of, after a while, you breathe your own exhaust. So we went into Great Places to Work, the only hospital involved. And while we got the award, we were shocked at how poorly we stacked up to leading private sector employers when it came to staff engagement. So there's a real takeaway for us. So we want to compare ourselves to the best, and that'll help us improve. We recently won the Order of Excellence from the National Quality Institute, which covers both quality of care and workplace wellness, a very sort of thorough and robust review process. Josh mentioned the this year's Healthcare Workplace Awards, and we were privileged to receive an award at the platinum level. Some of the numbers, absenteeism is dropping, and this has been a painful process, and we could have done it better, because some of our absenteeism programs is still viewed negatively by some of. It's intended to be supportive, but it's still viewed as punitive, and we have to do a better job. But it's working. The numbers are coming down. A couple of things to sort of highlight. This isn't a luxury, and it's back to what Josh said. We need to do this, and we need to do it even more in tough economic times. It's the only way we'll keep a sustainable system. We have to demonstrate the value through clear business cases that show a clear and measurable value proposition. And so often we don't do stuff because either A, we don't take the time to figure out the value return, or B, we just assume we can't afford it. And I'll use my needleless example as an example. You know, the easy thing to do would have been to say, we just can't go there because these are more expensive. We figured it out. We figured a way out to make the return. We've done the same on our safety initiative on reducing violence. The story Josh told about a nurse having a knife pulled on her. We've deployed across the whole enterprise at East General a voice-activated communicator. Every staff wears it. It's a light little thing. It has both a communications capability. You press the button and you can say, call the lab, and the nurse immediately is talking to the lab, or you can say, call hematology, you're talking to the hematology bench. But you can also press the button twice, and it automatically calls a code white. Every security officer in the building's device goes off, and we've reduced our response time on a code white to under a minute. And in a building that has over 1 million square feet of space, that is lightning fast. Had we just looked at that business case in isolation and looked at the cost to put in wireless infrastructure and the cost to buy the devices, we would have said we can't do it. But we stepped back and said, well, now let's get creative. What does it do for us in terms of reduced lost time? What does it do in terms of other productivity? We avoid all that back and forth in terms of nurse to pharmacy, pharmacy calling back, the nurse isn't there. We've patched it into the nurse call system. And as a result, we were able to become I think we still are the only hospital in the country to have it deployed hospital-wide. But it's the only way to deliver the return on it. They'll link the initiatives to patient safety. The communicator that we use, which we brought in as a staff safety device, when you could hook it up to a nurse call system, that's a patient safety initiative. When you start to think about the way it improves communication between members of a multidisciplinary team, that reduces risk of error. Because the biggest source of risk and error is miscommunication. This solves that. So there's a huge opportunity there. You've got to ensure that leadership as well, and we all as leaders, are active and engaged. That doesn't mean just making a commitment saying, yes, I support this project. It's not just, posting a statement as the CEO in elevators. We had a code white a few weeks ago. I responded. And I helped chase a guy down Coxwell. Thankfully, I didn't catch him. I'm a hockey player, and all I know how to do is sweater people. But the security guy's got the guy. but the point is, that's just part of the job. We're all there as part of the team, and we need to be engaged. And I just pressed the wrong button. Oh, perfect. I think as well, we always need to try our best, and I say this not just as leaders, I say this as frontline staff, as labor leaders, as funders. We need to present solutions, not problems. Too often in healthcare, we lament and whine about the issue and don't really move on to solutions. Engage labor aggressively. Organized labor has lots of good ideas. And while we don't always agree on things, there's a huge area where I think there's a lot of agreement. The challenge is going to be, through the next few years as we deal with fiscal pressures, hold the gains we've made. I think I've spoken to most of these ideas as well. I think it's so important to stay the course. The dividend in the long term is going to be huge, and it's all about sustaining our healthcare system. We don't have shortages of healthcare workers at East General. People want to work at our place. We don't have to pay people top-ups, clinicians, physicians, to come and do on-call. They want to work at our place because we've created this sort of environment. Further information, if you want more information on healthy workplaces and healthy work environments, is here. And I think with that, Josh and I'd be happy to answer any questions.
Now, Rob, I got to tell you, if you were in front of me and you said there will be absolutely no layoffs next quarter, I'd be worried about that following quarter. Anyway, so Josh, you and I were talking about doing a book. Longwoods has more stuff on this that you and I should talk about, and maybe Ross Baker would allow you to be a guest editor. I'd have to ask Ross. I'm not allowed to make these decisions. Ross is saying, what the hell do I do now? But we can talk about that because we do have a lot of material. Questions for Rob, for Josh? Where do we start? Here we go, Alex. Wait till you get the mic because otherwise the people on the webcast don't get it. Tepper, is he covered by WSIB? Are you covered by WSIB, Josh?
No, would be the long answer. So, do you... next question. No, so it's sort of I work in a bit of a quirky structure. It's all sort of fundraised. It's a bit of a quirky organization. I assume you're referring to my clinical environment and not the Ministry of Health. Oh, everywhere. Yeah, that's a good question. Adam, are we covered at the Ministry? I have no idea. We have definite uncertainty. That's a good question. I'll find out.
This afternoon.
Yeah.
Are there any more questions? Over here.
Good morning, thank you. My name is Peter Femmick. I work with an organization called the Community for Excellence in Health Governance. I wanted to commend you on this excellent expression of what is possible. And I wondered if you could speak a little bit about another organization that's interesting about the WSIB. Where does HIROC stand with this in the context of policy premiums?
So HIROC calculates their premiums based on your claims experience with patient care incidents. That being said, they have great interest in both workplace safety and obviously patient safety. HIROC as a partner have actually featured our personal communicator system in their newsletter as a way to promote it, and have been very encouraging of the sorts of things we're doing. And this is where, again, it's so important that we see the potential. This is, I almost think, I've used this analogy or this metaphor before. It's like a great big Scrabble board. And a lot of these initiatives are double and triple word plays. So the communicator we use is a triple word play. It improves staff safety, it improves patient safety, and it improves patient satisfaction. And when we start to see that potential, all of this stuff is possible even in a constrained environment.
I was intrigued with the concept of a family working within a unit and being self-supported, not only during good times but in bad. Did you manage to rationalize or get some compromise or commitment to the concept of bumping, which is generally a very disruptive process, especially once you've got training, once you've got that family support network?
In fact, the answer is no. We went through this major staffing change with lots of bumping, and in the middle of it realized, oh yeah, like it kind of hit us out of left field because we were so focused on the labor relations. In some ways, I think if we ever have to go through a change like that again, we will do it differently. We'll still have to follow the collective agreement, but I think following the collective agreement with a heavy overlay of staff support, whether it's through the EAP, occupational health, more focused conversations with the affected staff, that sort of thing. Like I think we'll do it, it'll be done in a much more understanding way. We still have to follow the collective agreement though. And I think this is where I think so often we view these things as, you know, a single track process. The contract says this, I didn't write the contract, it's not my fault. If you don't like the bumping process, you know, call the head office of your employee rep. And that's just the wrong answer. It's the hand we're dealt with, we've got to make it work.
Have you seen any impact to your patient satisfaction scores at the same time?
Yes. Now, we've done a whole bunch of changes simultaneously, so it'd be a bit disingenuous for me to say this has been the single thing that's changed it. But we've seen our staff scores grow on a number of the inpatient units. We've started doing post-discharge phone calls as an immediate way to get feedback as well, and we've seen the feedback through that mechanism go way up. One of the things the patients really like is the rapid response to call bell use. And one of the things we've also found is there is less call bell use. Now that we have communicators, and I mean, it's a bunch of things, a whole different staffing model with Q1 rounding. Our call bell use is down, and when they do call on many of the units, because it's patched into the communicator, it's instant access.
So, Rob and Josh, in appreciation for you doing this, I asked Ross Baker to be here today as the champion of patient safety, and he's promised to sign this book for you. I know you may have one, but if you don't, this one will be signed by Ross right afterwards.
Excellent.
And you can always pass it on to staff, right? Because I know both of you have read this. So thank you very much for coming today, and watch yourself in about 3 or 4 days. Eric, is that how long it is before we're up? Thank you very much. And coming next will be David Levine from Montreal. Thank you for coming to breakfast with the Chiefs.